Hello and welcome back to So You Got a Life Sci Degree. We are your hosts, Lisa and Farida, two life sci undergrad students trying to navigate our future careers. This is episode 8, and we're talking to Jacqueline Leonard about genetic counseling. How are you doing, Lisa?
I'm doing good. I'm super excited and done freaking out, but still very happy about the fact that I most likely have landed a thesis position.
Yay, so exciting.
Yeah, thank you. I feel scared about even saying that this chicken has fully hatched out of the egg because I'm like, they could drop me at any moment. I could accidentally send an email that's just all my Dragon dictation transcripts. I don't even know.
What are you dictating on Dragon that you can't share?
I don't know, but I don't know. I'm just like, I'm not saying these are logical concerns, but yeah, so I should be accepted for a thesis position in the Bramson lab, looking at how this synthetic or kind of modified T-cell receptor interacts with cancer cells. So for the people who don't know, T-cell therapy is a up-and-coming way for fighting cancer by essentially taking your T-cells, which are kind of immune cell from your body, kind of messing around with them a bit outside of your body and then putting them back in. And it's worked wonders, but they're trying to improve it.
Yeah, that's super exciting.
Yeah, so that should be, if all goes as planned, that should be starting in about a year. So the coming September for 8 months.
Nice.
That's a big end-year project. What about you? What's up?
Not too much. My hectic weekend has come to an end, which is nice. And I'm almost out of my floor fellow probationary period, so that's pretty exciting.
Almost? I thought you were already out.
I mean, I am. I just haven't done the probationary review, so.
Oh, I see.
Yeah, no, I haven't gotten.
What if you never do the reviews?
I don't think they'll let you get away with that. Yeah, but basically, my boss emailed me and was like, "I can, assure you it's going to be a positive review." So basically, telling me I passed. Yeah.
Aww. So does that mean that they can't drop you now? Is this like the floor fellow equivalent of getting tenure?
It is the equivalent, but it's not exactly getting tenure because, it just means that the things you have to do to get fired are even more outrageous than before.
That's basically tenure. Cool. Glad to hear you've been accepted into the inner fold.
Thanks, me too. I could relax a little bit.
So I'm super excited to talk to Jacqueline because upon reaching out to her, we didn't even realize exactly what her specialty was. We just knew she was a genetic counselor. And then through emailing her, we found out all this extra exciting information. So I don't know about you, but I'm really eager for this interview.
Yeah, her work seems super cool. Ready to talk to her?
Jacqueline is currently a genetic counselor at the Children's Hospital of Philadelphia. She completed her undergrad degree in molecular biology and genetics at Mcmaster University, followed by a research master's in pathology and molecular medicine at Queen's University. She then completed a clinical master's degree in genetic counseling at Brandeis University in Massachusetts. She began working at the Children's Hospital of Philadelphia in 2017. In addition to pediatric genetic care, she has added interest and specialty in differences of sex development and intersex genetic etiologies. Thank you so much for joining us today, Jackie.
Very happy to be here.
So the first question that we wanted to ask you, because not necessarily everyone knows, is what do genetic counselors do?
So genetic counselors really do clinical work, but also have really started to move into labs and industry. From a clinical perspective, we really are kind of a bridge, I think, between sort of the complex genetic literature and the geneticists and patient and families. So we work to help families understand the process of genetic testing, what things mean, types of results, help them understand their genetic risk factors by taking things like family history and review of systems, helping them understand results when they come back, as well as doing psychosocial counseling, making sure families understanding the process and how they're feeling about it. From the more industry side, working in labs, helping write test reports, things like that. It has been a growing role too.
Sounds very interesting. Could you possibly give us some examples of cases that you've worked on?
Sure. So the types of cases I can see really depend on what the referral is. So I'm very lucky to actually work in a division where our goal was to provide comprehensive genetic care for divisions outside of the sort of typical genetics realm. My division really helps, like, is if immunology wants to send genetic testing, rheumatology, GI, nephrology. The classic sort of what we think of as genetic referrals can be individual with history of developmental delay, autism, intellectual disability, or multiple congenital anomalies. We do see many of those patients, but those can often go to another genetics division where I work. But I see individuals where they're a 15-year-old female that has had significant respiratory infections throughout her life and abnormalities on her blood work, where maybe her immunologist is concerned for immunodeficiency. So we would help send a primary immunodeficiency panel. An example of a case I just saw yesterday was a 3-year-old male with a history of macrocephaly, so really large head size, developmental delay, complex ketotic hypoglycemia, and a heart difference that had prior normal genetic testing, where we are sending a test called an exome sequence, which allows us to examine all 20,000 of somebody's genes while being very personalized. So I would tell the lab, hey, make sure check all genes known to be associated with macrocephaly, and et cetera, for all their different features, and really sort of maximizing a chance by finding an answer with a single test. With my additional DSD, difference of sex development, and intersex background, we see a lot of kiddos born with genital ambiguity, where they're possibly in the process of trying to determine best gender of rearing. So often in a case of ambiguous genitalia, there can be an XX karyotype, but maybe genitalia more towards the male, or the gonads more towards testes or ovaries. There's something called mini puberty of infancy, where at 2 months of age, you would get a kind of a spike of hormones that would be consistent with actual puberty. So is there more towards estrogen or testosterone? And we get involved as part of what's the underlying genetic diagnosis. Could that help us determine and continue to make our recommendation for gender of rearing? And very often, actually, in those cases, we're able to identify underlying etiology and diagnosis for the family, be sure we're not missing anything else with those. So I kind of see a fairly large breadth of patients, which I feel quite lucky to do.
That is super cool. I don't even know where to begin. I have so many questions stemming off of that, but I guess to go back a bit to the basics of what you do, you mentioned that, you know, on the clinical side, or on the family side rather, sorry if I'm mixing that up, you are kind of the bridge between the medical professionals and, you know, be able to talk one-on-one with families and help them through difficult situations. And so can you just walk us through what that looks like? Is this like a counseling situation where you see them once a month or once a week?
So most of our appointments do tend to be sort of one-offs to two-offs. So see the family initially for genetic counseling and a genetic evaluation, and then potentially for result return and follow-up. We certainly work with social workers, and I've certainly referred patients to psychologists if we feel like they need more psychosocial support. But generally, we just tend to be kind of two-offs. In terms of a standard patient visit, I'll be the one that spends the majority of the time with the family. And normally visits are kind of patient, being a child, and mom and dad typically. Can just be mom, can just be dad. We've had all generally we need consent from a parent, which is why it's usually not somebody else bringing in the child. But we take a comprehensive history, go through pregnancy history, developmental review of systems. So I ask, like, any concerns for vision, any concerns for hearing, ever been told you need to get his heart checked type thing, and then take a comprehensive family history. Sometimes the patient is in for multiple congenital anomalies with talking about the exome test, and I notice like a family history of early onset cancer, maybe concern for early onset heart differences. So family histories can really be a larger risk assessment picture, where sometimes I have to be like, so I know this isn't necessarily what you were expecting on coming in today, but I noticed this history. Has this person ever considered further genetic testing for that, like family history of additional? And sometimes we refer families to other places for those. And then really counseling through the test, what it is exactly, what are the exact types of results, what does a positive mean, what does a negative mean. Very often we actually get uncertain results. I talk a lot to families about the fact that just because a genetic change is found doesn't actually mean it's doing anything.
Mhm.
In the genetics world, we're really kind of moving on from using the term mutation, and that's because variants can be of what we call uncertain significance. So
Mhm.
it's a change, maybe it's doing something, but we can't say that for certain because oftentimes we've not seen it before. So we're often moving on to the term like pathogenic variant in the case of what we would refer to as a mutation. So it's kind of talking through all of that. And often the sort of psychosocial counseling I can do in a session is to the perspective, like what would it mean to identify a diagnosis? Would that something be helpful to you as a family? All genetic testing is always voluntary. So I always like to emphasize the fact that, like, if this is helpful, we can definitely do it. Oftentimes we already have the insurance approval, which is something totally separate in the US from healthcare. But it's important to me in my counseling sessions to know, like, being sure that the family wants to go ahead and it's something that's helpful to them rather than them just saying yes because they're here for that visit and that test. So oftentimes psychosocial counseling really comes in on the back end with results as well, because diagnoses can be extremely overwhelming times for anybody. So being sure family is sort of aware of the results and what it means, but be kind of meeting them where they are. At the same time, often this can involve kind of a couple different phone calls over time, because I always sort of ask family, how much do you want me to talk about this? I can talk about it a lot. I can talk about it just sort of to a brief degree. We can touch base on it again in a couple days. So it can very much depend on it's kind of meeting the family where they are in terms of that diagnosis conversation as well.
Yeah, that sounds like a super interesting role. Seems like a mix between interpreting results, kind of providing them guidance to further action, but also then providing that, emotional support, which seems super important.
I like that a lot about my job. It's also, I think, we're kind of a bridge between, like, I have to take complex papers in the literature about diagnoses sometimes we do offer papers to families if it's something that's helpful, but I often find my job is, in terms of result return, is like I have to take these papers and be able to talk to the family about it at a level that makes sense. And it's just kind of regurgitating complex medical information. So I very much like that, like in my sort of intellectual standpoint, I get to be reading a lot of papers, interpreting things. I feel very lucky at CHOP that they have a high degree of like trust in their counselors. So my clinicians and geneticists often do trust my sort of opinion about results, which I feel very lucky about. And interpreting that information for families is also a big part of what I do.
It's cool that you like still get to interact with the science so much. That's very interesting. And you work specifically more on the pediatric genetic care, from what I understand. Could you speak a little bit about the other kinds of divisions of genetic counselors in hospitals or other settings?
Absolutely. So, in all honesty, genetic counseling, I think, is a field that's growing a lot and growing into a lot of different areas. So a lot of people can kind of take their interests, and you don't just have to sort of exit out of a genetic counseling degree and go into clinical care. So across clinical care, we often consider the main three areas to be pediatrics, prenatal, and cancer predisposition. So prenatal being offering testing for what they term advanced maternal age, which I don't necessarily agree is always the right term, but individuals who are pregnant, who are over the age of 35, are at a slightly increased risk for certain trisomies like Down syndrome. So often prenatal counselors help families to understand screening tests about someone high risk or low risk, or see families when there's anomalies on ultrasound to counsel, well, what could the differential be? Would they be interested in testing during a pregnancy? Cancer predisposition clinics very much focus on like individuals with family history of cancer. From a genetic perspective, we do become concerned, could there be an underlying genetic cause when there is a family history of cancer under the age of 50? So just yesterday, I had to counsel. So like, even though I work in pediatrics, sometimes I have to pull out these hats where I saw a family history of patient's grandmother had a history of breast cancer at age of 45. So I put on my cancer hat and was just like, so whenever we see someone with this history, we do become concerned. Has she had testing? Would you consider testing? And that would be the whole sort of cancer clinicians job.
Mhm.
They'd be looking at these family histories, determining risk, and sending testing based off the indication. So they mostly focused on colorectal cancer genes or kidney cancer genes or breast cancer, etc. But increasingly, genetic counselors work more in laboratories and industry. I work with a number of laboratory genetic counselors that help to write reports and work on the kind of genetic testing lab side of things. I work with another laboratory genetic counselor that primarily is involved in research, so she helps run some large studies that are done in collaboration with some of the geneticists I work with. So she helps to write documentations and IRBs and sort of help manage that study. Across clinical realms, people specialize in cardiovascular care, adult genetics, psychiatric conditions, neuromuscular, neurology, metabolic, mitochondrial. Many different clinic areas help employ genetic counselors now, and increasingly we're getting involved in many different areas because I think the ultimate skill set we have of sort of taking complex information and helping families understand that and kind of converting that down, I think can apply to a lot of different areas, and more industries are recognizing that.
Yeah, it almost seems like every area that you could have a doctor for, you could, in some sense, also have a genetic counselor for. Definitely seems like a useful position. And, in hearing you talk about having to work with people who, might have a predisposition for cancer or are at an increased risk of having trisomies, it seems like as a genetic counselor, you inherently have to give a lot of bad news to patients or, work with them through difficult times. And so I was wondering if there was, some kind of emotional toll to this or, how you manage this kind of emotionally challenging situation.
Yeah, that's a good question. I think you did absolutely pick up on that correctly, that we do often have to give a lot of bad news, or what we would consider. In pediatrics, I often feel like a result can mean different things to different people. So I often really try and avoid putting like my judgment on how family would feel unless before they tell me, since a diagnosis of significant intellectual disability and developmental delay in a patient that's only presented maybe with a congenital diaphragmatic hernia, where that's when the diaphragm doesn't fully close, it's a little bit open, and abdomen organs can actually make its way up. And I've had situations where I've disclosed results where it's devastating to the family, and that is hard. Those are often the kind of days where I feel lucky to be able to decompress with my fellow counselors and colleagues, along with friends and family. Burnout is definitely very real in clinical genetic counseling, and often many groups see sort of a move of like somebody works in clinic for like 5-10 years and moves to industry. But for me, it's kind of how do I manage that burnout? But at the same time, that same diagnosis that was devastating to that like 4-month-old child's parents can actually be incredibly relieving to a 16-year-old's parents who have been looking for an answer for all of that time. So I've had families where I feel very lucky to kind of go through that, and they've given me a hug at the end of our results disclosure.
Yeah.
That's just like we've been wanting an answer. So that's why I'm like, I always try and sort of avoid putting any emotions until kind of family kind of gives me some indication, which has been made harder in COVID when it's a lot more by telephone, I admit. I think this is very much where different people choose different types of clinic areas. For me, I really liked pediatrics because like the variable indications, and often because it's more of a like you're giving an answer for something you already know is present, versus a couple times I've had to give diagnoses of, well, part of the big test, the exome test I do does revolve around additional predisposition genes we can look for. So I've had to give diagnoses surrounding like cancer predispositions, cardiomyopathies, arrhythmias before unexpectedly. So I can speak maybe a little bit to how those counselors might feel, but not completely. But like that's hard when they're not necessarily expecting that, and all of a sudden you're telling them that there's this increased risk, and that's hard for some families to hear. And I think like those all depending on kind of your area, how individuals best cope. But yeah, it's certainly part of the job, and I think managing burnout with that is something that I think every counselor has to go through. But personally, I think it's worth it for, I think, always still helping families be able to go through this process and being with them through it.
Yeah. I mean, I can relate to that. I mean, me, myself, I have this kind of confusing, like chronic pain condition in hands and just all these symptoms that don't even seem to make sense. I've had, physiotherapists and doctors and rheumatologists not know what's going on. So yeah, I definitely know what you mean when you're like, some people are just relieved to know because it's so much easier when you have a diagnosis.
And I can only imagine how frustrating that's been even for you as you've gone to all these doctors. That's tough.
Yeah, for sure. Actually hearing you talk about this in the back of my mind, I'm like, oh, maybe I should do genetic counseling. And so that kind of led me to thinking, what is the process of a patient actually ending up in your office for genetic counseling?
So most of us are present in hospitals and kind of entrenched in systems. Unfortunately, at least in the States, and I believe it's the same way back home, genetic counselors can't practice necessarily wholly independently. We have to be involved with a physician. There are certainly groups working to have more direct access to families in genetic care, because I think that's something really important, that a family could just be like, genetic counselors in my area. But that's certainly something more worked on. But it really depends on the indication. So we would get many referrals from like pediatricians. In terms of cancer predisposition history, I know many of those come from like general like PCPs of like, hey, I'm noticing this history. I think maybe you should see this, but they don't always necessarily need to come from a doctor. I know like Sunnybrook has a predisposition clinic where I think you can just kind of call and book an appointment based off your concern. There's a prenatal clinic I know at Mount Sinai back home that I think is fairly similar. Though don't necessarily quote me on that. I briefly interned at Sick Kids where it was mostly, we saw patients referred from other divisions of the hospital as well as pediatricians. So I would say most of it is probably referral from someone's healthcare provider. But certainly I think more and more as the field becomes more well known, people are searching us more out on their own.
Nice. So you mentioned it's usually based on if people have like a predisposition. Could you explain a little bit of like how that might present?
So we use the term predisposition mostly to refer to somebody has a pathogenic change in a gene causing them to have an increased risk for something in their life. And those can really be actually through a number of different categories. A lot of them, and why we really sort of call them predispositions and not necessarily syndromes, is that most of them have what we call decreased penetrance. So just because you have a change in a gene doesn't mean you'll have symptoms, but there is certainly a risk. A lot of people come to the attention in like cancer predisposition clinics or cardiovascular clinics, for instance, because of a family history. Like I know my mom had this early onset colorectal cancer. I'm concerned about my risk. I would like to get tested for genes related to that. Or I had a sister who had a really early onset heart attack in her 20s, and I'm concerned about could there have been a reason for that. And normally in those cases, we'd always say best person to test is the person affected, because we can always say a negative in a person with no symptoms is not necessarily as informative, because it's possible there's still something in the family that other person just doesn't carry. But I'd say majority come to attention either because like I have this family history, or I have actually presented with this finding, and I'm concerned about what risk for the future I might have as well.
Yeah, and it makes sense to describe it as a predisposition because, if you think about cancer, it's not like you mutate one gene and you're going to get breast cancer. You need several, mutations on top of one another. So I'm sure a lot of genetic diseases are polygenic, meaning, they're affected by multiple genes.
Actually, your first instance is actually, I would say, most correct. So when we would consider a predisposition, most of them are dominant, so you only need a single pathogenic variant. But we think of like BRCA as some of the most common predispositions, where all somebody needs to have the predisposition is a single pathogenic variant in BRCA1. And then we would consider the two-hit hypothesis from there. So to actually develop disease, we think they really need to get a second variant somatically on the other allele. And that's why it takes all that time. It's why we don't necessarily say somebody needs breast cancer screening with a BRCA1 change until they hit 25. But polygenic, I would say, is less the realm of genetic counseling, because most of those are actually sort of really shaky in terms of their clinical relationship and their clinical care. Most of what we really deal with is these monogenic, single gene, single hit in the case of dominant, or two hit in the case of recessive diagnoses.
Yeah, I guess the science still needs to get there before you can really apply that in clinic.
I get asked so often, can you look for diabetes? Can you look for Parkinson's? Can you look for Alzheimer's? And I have to say, no, not unfortunately, not really. The science is shaky. We're still learning a lot about what it means.
Yeah.
So those are still areas, I think, of a lot of ongoing research.
Yeah, and definitely makes sense that this is a field that's growing, because as we find out more about different diseases, there's more possibilities for application.
Very much so. I tell families all the time, and the fact that I send that exome test I mentioned, I'd say most, that's a test I send the most commonly. I also have to say, like, we really only have a 30% chance of being able to identify an answer with a suspicion of a genetic cause. And that's really because as much as we can get the data of all of our genes in that test, we really only know how to interpret, we say, kind of like 6,500, 7,000 of those genes and the changes within them. And there's about kind of 13,000 genes where we still have to learn a lot. And we're certainly learning more every year. We kind of quote, we learn about 200 to 300 new genes a year.
That's really cool. And now backtracking a bit and, you know, maybe getting off some of the tougher topics and asking you a bit about your educational path. We were wondering why you chose to study molecular biology and genetics at Mcmaster, and, you know, at the time, as, you know, an 18-something-year-old, what were you envisioning for your future career?
That's a great question. So to initially preface it, I didn't even hear about genetic counseling until my 4th year of undergrad, after I had already accepted a research master's position. So I think the field has like grown a lot, that it's becoming more well known, but I think definitely, and part of why I was really glad to be asked to come on is that I think telling people that this career is out there, I think it is important. But in terms of when I entered, I always really knew I loved biology and I loved genetics. So I was super happy when I got into that molecular biology and genetics program. At the time, I thought I wanted to do research. I always knew I didn't want to be a doctor, but I knew I wanted to try and do, I thought I wanted to try and do something that allowed me to find out more for families and ideally be able to find something that helps somebody in the future.
I feel like we're interviewing Lisa in the future. You're
I was just about to say that's
word describing Lisa.
Literally me. Yeah, I loved bio in high school. Wanted to do research. Still kind of do, but same program and everything too. So yeah. Anyways, you were talking about how you wanted to help families and discover more things.
Yep. So part of why I really liked the molecular biology and genetics program instead of just the general biology track is, I don't know if it's still the case, but it mandated the thesis. Yes. And it mandated that 3rd year class where it's only the 30 of you doing lab work twice a week.
Oh, that's still changed.
Oh, that's changed. Oh, okay. So there used to be that. So for me, I liked it because it would give me some research skills that I could translate into a thesis. And I knew I really wanted to do that thesis. Going from there, I always sort of was I enjoyed my thesis. I enjoyed those research classes. I want to continue on to do something. And my research master's did focus on the genes related to hemophilia. So
the
royal disease, yeah. So I was doing kind of not necessarily genetics work, but sort of molecular work to sort of better characterize how these things act under stress in the bloodstream. I thought if we know that, how can we sort of use this information in the future? And then I admit that while I did enjoy research, it is a tough path. And for some who are great at it, I applaud them and I admire them deeply. But for me, it was somewhat isolationist. And I grew frustrated with the fact that you could do an experiment many times and fail often. And that was just tough for me personally. And I kind of grew to the fact that I wanted to work with people more. So I sort of remembered back to the fact that I had heard about genetic counseling. I reached out to the friend that I had heard it from, who by then was in a genetic counseling program in New York. And she sort of helped me talk through things. I was able to shadow a genetic counselor in Kingston, and sort of was like, I think this combines a lot of what I want to do. It's not taking me away from the science that I love. I still have to sort of be able to use my brain in that way. And I feel very lucky now that like my name is on papers in terms of characterizing new disease genes, and I'm currently sort of writing a new one up now, that like you can use that like clinical work and finding out these genetic information, and then actually do at least some clinical work on that and still get published. And I feel very lucky I'm still able to like contribute to the literature in that way, even though I wasn't necessarily like, it's a different way to kind of go about it. And I get to interact with patients and I get to interact with people. And I do feel very lucky that I found genetic counseling as a career.
That sounds really cool. You mentioned that you got to shadow a genetic counselor for a little bit, and that kind of informed your future career decisions. Could you just speak a little bit about that experience?
Sure. It was really only, I think, a day. It was unfortunately all I could get offered, but I got to shadow a couple sessions. I believe she was a cancer counselor, and I always remember her telling me, like, there's a lot of paperwork in this job. So like if you hate that, this isn't necessarily for you. But I still don't mind it. But it was a result return for something that one of the cases I got to see, and I just was really entranced by how the counselor helped the family through and was explaining things, and it was certainly formative, and convinced me that was definitely something I wish to go forward with.
Very nice. And the other question is kind of, what does the Master's in Genetic Counseling program look like, and what are the qualifications to become a genetic counselor?
So in terms of programs, there are certainly a number in Canada, but to my last check, I think there's 5. And they don't necessarily accept a lot of students each. So it is actually, unfortunately, very common that Canadian students end up in programs in the States. Of my program of 10 students, 3 of us were Canadian, all from the Toronto area.
10 students in a program, that's so small. Like, I guess per year, is that what you mean?
Per year, yeah.
Wow.
And that's large for a genetic counseling class.
Oh gosh.
Wow.
The largest is around 20. So these are not large programs, but at least in the States, there's a large number of them. Most people come out from biology degrees or psychology degrees, but what I think is great is increasingly more people are like genetic counseling as a second career. People were in research for a little bit of going into it. So increasingly people are coming from a lot of different backgrounds, which I think is great. Because all you really need is, like, you do need biology classes, you need like organic chemistry, some psychology courses. But outside of that, you can kind of come from any background. A lot of programs really look for some kind of shadowing experience. They really want to be sure like you understand what genetic counseling is and really want to pursue that as your first choice. So they look for
they don't want med school people who didn't get into med school.
Essentially, yeah. Or I think they want to be sure, because like there's so little program spots, they want to be sure you want it and have done the research, and programs really do look for that. So like, has someone been a genetic counseling assistant? So I think if someone's really interested in genetic counseling, a lot of divisions will hire genetic counseling assistants. So they'll help put together things, and that can be a good experience for somebody interested in the field. Has somebody shadowed, for how long? One of the other things they look for is kind of advocacy or counseling experience. So I worked at a text crisis chat for a year. So people work at like counseling centers, crisis centers. One of my colleagues in my program worked at the Special Olympics for a number of years.
Wow.
So kind of that like disability advocacy, a lot of programs like to see. That's not necessarily as required as like they really want to see some sort of counseling experience. In terms of going to the States, I believe only one program doesn't require the GRE, which is Sarah Lawrence College. All others do, though I know more are moving away from it. So I did have to take the GRE, as my program that I did get into required it. Different programs I often say have a focus on kind of like, do they focus on the science or do they focus on the psychosocial? For me, I was really looking for a program that focused on the psychosocial, since I felt with my background, how Mcmaster prepared me, and the fact that I had been doing research for 2 years by that point, that I could teach myself the science. I felt comfortable reading papers, but I really wanted to learn the psychosocial. So when I was interviewing, that was important to me, of like how much that was a part of the curriculum. But any program is accredited by the organization that, like, if you graduate from, you'll do the certification to exams. They all have to teach somewhat of the same things. So like you'll learn psychosocial care and sort of fundamentals of that. You'll learn the kind of 50 plus genetic diseases everybody should know. Often that will involve like going over cases and lectures about like genetic conditions across different body areas. I had a class regarding like healthcare and like what is insurance, and like in the States there's all kind of weird things about insurance. So
that sounds like a super useful course.
I did. It was like, what's a deductible? I don't know what a deductible is. So thankfully it was that, but there was also like a disparities in health course, just kind of fundamentals of genetic counseling, where we had like a family come in to speak that were diagnosed with a cancer predisposition syndrome, or a mom come in to speak whose daughter was diagnosed with Rett syndrome or Prader-Willi or some genetic conditions, where we really heard the family perspective of their process and how genetic counseling was for them. And that was part of my program. Also like had us entrenched with the family in our first year, which I thought was great. But all programs will kind of help teach you the medical part of it, the fundamentals of like how do you take a family history, how do you take a pedigree, and the psychosocial part. All programs will involve clinical rotations, at least 3, or typically closer to sort of 5 or 6, that will have you as a student entrenched in a clinic. They're usually a number of days a week. So you have the practical experience of across all different major divisions. So I had a cancer rotation, I had a prenatal rotation, I had a pediatric rotation, and you have to have a certain amount of cases that you submit to the accreditation organization before you're like got the check off that you can like write the certification exam. So there's certainly classes, but the clinic rotation is a big part of it too.
Right. Super cool. And so now switching back, you mentioned when we were corresponding with you that you are interested in differences in sex development and intersex genetic etiology. So I was wondering a bit on how you became interested in this. And I know we talked about this a bit at the beginning, but, like elaborate a bit more on what is your role in helping families navigate these kinds of conditions?
In terms of my specialty, I was really very lucky in that when I interviewed for my job, they had a physician that really wanted to start this clinic, and they knew that whoever was hired was going to be like that a physician's partner. And I admit that was part of why I really wanted my job when I heard about that. Mostly because I think it's kind of crossing over to like LGBTQIA advocacy that I've always kind of been interested in and thought was really important, because a lot of my patients, many people, how they identify over time is very variable and up to them. But certainly people that identify as intersex really have this crossover, I think, with this question of genetics and could there be an underlying genetic reason why they were born with the differences that they've been born with, because there really is a structural component. So my role can often be at different stages. We probably see patients most commonly in like 2 different parts of their life. And firstly, that's when they're born. So baby, for instance, family was told, oh, you're having a boy by ultrasound, and then patient's born, and then they have hypospadias. So I mean, the opening, urethral opening isn't at the tip, but at the base. Orchidism, so their testes are up in the body and not dropped down. There are a couple other structural abnormalities, and all of a sudden it's kind of that what you would consider, oh, it's a boy, oh, it's a girl, and these families don't necessarily get to have that same experience, because all of a sudden uncertainty is thrown in. There's a lot of cultural work that goes on, that like there's such this societal expectation of like it's a boy, it's a girl, that when families can't say one way or the other, that's really hard. There's data to suggest that a diagnosis of genital ambiguity is as hard on a family as a diagnosis of childhood cancer. One is not life-threatening, one is. And I think that speaks to how significant that sort of question of gender can be for families.
Yeah.
So I feel really lucky that like we have discussions about where a family is gender revealing and a recommendation from us something that's important? Because often a genetic diet, like how is finding an answer something that's important? So how can that testing that we consider help them through that? We work very closely with endocrinology, urology, sometimes ethics, gynecology, sometimes social work, and psychology, often as a multidisciplinary team for many of these families. And it's kind of like, how have you been talking about this to people? How are you referring to baby and mirroring family in that? Having these discussions of it's important to be open as child grows. There's a lot of data suggests that there's a lot of negative psychosocial impact on adults if family was really like secretive about their diagnosis.
Right.
So we have a lot of conversations about why it's important to be open. How do you best talk about these things as a child grows? So there's a lot of good resources that say, well, at 0 to 6 years old, you can talk about these things, that like all bodies are a little different, but maybe by age like 10, you start to discuss hormones and what these things look like. So we really try and follow families every year or so to see how they're doing, even if they already have an answer. I'd say the other thing that sometimes factors in is question of surgery. So there's a lot of current controversy from actual affected people saying, I didn't agree to this. This was mostly for like plastic purposes.
Yeah, like for appearance purposes.
Yeah. And I like have side effects based off that, and I'm not comfortable like with the fact that this happened to me. And so there's these questions surrounding like consent. So it's this question of like appearance versus function. How much do we want to wait to have irreversible decisions until child is old enough to consent themselves? So these are discussions we're starting to have more and more, but it does come with the fact that we allow parents to make medical decisions all the time for their children.
I was just about to say, like, you know, parents decide if their kids get vaccinated, so it's so interesting to think about consent in this way.
Or like heart surgery or all these kinds of surgeries you allow. But I think it's still really important to like listen to these advocacy groups. And I think they bring up incredibly valid points that we bring up to our families all the time, being like, just because you've been told that you have surgery as an option, like you don't have to do it. This is why some families say yes. This is why families say no. We bring up the sort of that oftentimes these can wait until child's old enough to make a decision to whether they want to undergo that themselves. There's this kind of entrenched medical belief that like we've done this for so long. And I think a lot of groups are hearing pushback from these individuals as they're older, and that's created its own kind of controversy that we bring up to families in our sessions. So that can be its own, and ultimately whatever family grows with, we support, but we always at least like to just make sure that they know that there's an option. And so the other time families come to attention is in puberty, where, for instance, a 15-year-old girl hasn't had her period yet. She gets an ultrasound, finds that there's a lack of uterus and ovaries, and there appears to be testes, and they're identified to be XY. That is most commonly a condition called androgen insensitivity syndrome. These girls are totally typical. Most of them keep with a female gender identity. That's another thing we always talk about, even with babies, that we can always make our best guess with gender revealing, but ultimately listen to patient, that they'll tell us kind of how they feel as they grow. But most of androgen insensitivity patients are fairly stable, but that's an incredibly like difficult time for patient and family, because all of a sudden they've always been told their whole life XY is boy. And I live in a realm where that's not the case a lot of the time. But that's still an incredibly hard thing that these families struggle with, of this like discordance in how they feel versus what they've been told. So helping kind of families, like often I'll just always ask like, how you doing? How are you been talking to people? How do you feel about this? And sometimes just like don't necessarily get a lot back, but I always feel it's important to ask those questions. And still, so I have that psychosocial piece, I think, a lot more in my like DSD program than in some other areas of my clinic space, just because ultimately the vast majority of these conditions are not syndromic. Very, very rarely are they syndromic. I mostly deal in the realm of non-syndromic, isolated genital ambiguity. So there's generally not a lot of other health concerns. Most of these kiddos are perfectly healthy when they're born and have no other issues. And so it's this kind of, we sometimes give to families that like, congratulations, you made a baby. And we always like make that point of still saying congratulations to these new parents and kind of being with them through the process, because there's such this sort of gender sex cultural and societal places of these things and what we expect, I've realized how entrenched they are in my clinic.
Yeah, you just covered so much stuff. I'm amazed at how well you've been able to cover so many different topics. And it's so nice to hear that even in the medical perspective, you guys are integrating the sociological side a lot. So that's really nice to see. And I just wanted to briefly ask if you could give an idea of like how many intersex people there are, if you have any approximation.
So it's about 1% of the population with variable features, but it's kind of truly like general ambiguity is about 1 in 4,500.
Okay, very interesting.
So it's not super common, but like
it's way more than you'd expect.
I think it's ignored like how still often this does occur, and it's not really something that we ever talk about. And like we certainly I have my clinic once a week, and we certainly at least have a new patient a week.
And I've heard about androgen insensitivity syndrome before, but I find it so cool how people who are raised, who are XY, who are raised as a girl, I guess also because they have traditionally feminine features externally, I find it really interesting how they continue to identify as female even after they're told what their chromosomes are. So that's also super interesting.
Well, think about what does an androgen insensitivity syndrome mean? So androgens, testosterone. It's a variance in the androgen receptor gene. So complete androgen sensitivity syndrome. So partial causes general ambiguity, but complete are these full phenotypic women. And that means they cannot sense any testosterone. Their body makes it, but they can't sense it at all. So they're kind of not getting any of what we would consider these quote unquote male factors, even with their XY karyotype.
Yeah, super cool. So kind of going back more to your interactions with patients, I know that me, as someone who's seen a lot of doctors, has been shunted between, rheumatologists and family doctors and all these different kinds of people. One of the things that I think me and a lot of other patients find super frustrating is, and I'm sure it's different in the States, but is how in Canada, at least, the doctor-patient interaction is very rushed. You see a rheumatologist and you see them for maybe 5 minutes. You have to drive an hour to get there. You waited 30 minutes in the waiting room. They look at you and they're like, okay, let's increase your dosage. And I think it's super frustrating, I think sometimes how, there's like this lack of connection and they don't even know who you are until they look at their clipboard. And so I was wondering, like you mentioned, you do work more intimately with these families, but that you also do only see them, once a year or just once or twice as a one-off. So how do you feel about, I guess, the connections that you develop with your patients? Is it ever difficult to maintain that genuine connection within the confines of your work?
That's a really interesting question. It's something that I feel very lucky as a genetic counselor that I do get to spend a lot of time with families in the room. So our geneticist really maybe only spends a couple minutes with the patient as well. But of an hour-long appointment, I'm spending 45 minutes with them. So I feel very lucky that I am in this position where I can spend the time and can listen to their concerns. And it is sometimes difficult to sort of keep that connection because sometimes in my division, if the referring provider wants to be the one to return the results, I may only ever have seen that family once. That's sometimes too bad. But I have to go with the referring provider because they were the one that sent the patient. But that's why I feel lucky that I have my DSD program, that I do often see families back with more continuity of care. And I always try to keep that continuity as much as possible. But sometimes that can be a place where like different genetic counselors, depending on the area of practice, are able to get more. So some of the neuromuscular counselors at CHOP do gain a lot more of that continuity and relationship with families more than I do, because most of the patients I see are kind of those 1 to 2 offs. But I still feel very lucky for the fact that I can sit with them for at least that bit of time. And I try and keep up that continuity as much as I can.
Yeah, it's definitely tough because, it's a fast moving system and there's high demand and low supply. So yeah, it's definitely a hard thing to navigate on both sides. I do have one more question for you. I was wondering, you talked about exome sequencing a lot. And obviously, genetic counseling is something that relies heavily on biotechnology. And so I was wondering if you could elaborate a bit on, maybe 2 to 3 techniques that you use a lot as a genetic counselor and what kinds of data you're able to get from those techniques.
Like molecular techniques?
Yes, molecular techniques like exome sequencing or, other kinds of similar techniques.
So exome is probably the most common. The exome platform is kind of unique, and you're getting more and more tests that are what we call exome slices. So they still get all the data, but only focus in their attention on a certain number of genes.
Do you want to just briefly explain what exome sequencing is?
Oh, yes. Sorry. I will.
It's
I will
just,
mention that
like,
again.
yeah, it's just like the color red to you.
Sorry, I thought I mentioned it a little bit at the beginning, but an exome is a next generation platform that allows us to get the data of all 20,000 of somebody's genes. Then the analysis pipeline goes through the millions of variants on the kind of laboratory side in order to kind of filter through towards what we might actually consider to be like the pathogenic variant causing that patient's differences. I also am lucky to be involved, like my division works very closely with the lab. We do the exome tests in-house. So we're also involved in the clinical correlation step where we get given, here are 12 genes that came back on the exome test. Do you think they clinically correlate to the patient's phenotype? So we say like, yes, we agree that you should report this because we think it might be the answer. No, we don't think you should report this because this doesn't have any overlap. So we work with the lab to give our clinical perspective on kind of the before the report writing stage.
Mm-hmm.
We send a lot of panels, tend to be mostly next generation sequencing that like only look at a certain number of genes based off a particular phenotype. So for instance, I'll send like monogenic obesity panels or ambiguous genitalia panels sometimes. So most we send exomes on those patients, or immunodeficiency panels or periodic fever panels that only look at a certain number of genes, but they're not on the exome platform. So it kind of only looks at those specific ones. And then we do Sanger sometimes for specific like single gene tests. So one gene I work a lot with is associated with a condition called congenital adrenal hyperplasia, which is a recessive condition that is tested on the newborn screen for every baby born in North America because it can cause salt wasting really early in life. So you need to get these kiddos on medication really early. But it also causes genital ambiguity in XX individuals because it sort of through the pathway involves an increase of testosterone. And that gene has a pseudogene right beside it. The most common genetic change in that gene is I can't remember the exact word, this is terrible, but I think transposition of the pseudogene into the actual gene.
Oh.
So it looks like 6 different variants on a report, but it has to be Sangered, and you can't really do it next generation sequencing because the pseudogene and the actual gene are very similar in other sequences. So that's probably one we send that kind of platform very, very frequently.
That's so interesting. I didn't realize that Sanger sequencing was still used at all. So
oh yeah. I was surprised too. We've been learning about it in class, and I was like, "Wait, really?"
Yeah,
it's modified. It's not the original, but
yeah, that makes sense.
It's also used a lot to confirm variants on next generation sequencing platforms. So you could have your next generation sequencing, you have a bunch of reads from this variant in order to confirm that it's really there. Like for something to make a clinical report, it generally always has to be Sanger confirmed.
Very
Super cool.
Okay, we are running a little bit over time, so I think we should wrap things up. Thank you so much, Jackie, for talking to us. And before we end things, is there anything else that you'd like to add?
I guess just because I didn't really mention it earlier, but I know I've talked a lot about why I love genetic counseling and that I get to interact with patients and take literature, but there's a lot of ways that genetic counselor can get involved with things besides just the clinic. So I'm trying to get involved with more advocacy work and actually advocacy groups, education. I help teach classes. I'm involved in a committee as part of the local program. I think and kind of publishing and research, even as a clinical counselor. So I think genetic counseling can be a lot of what somebody makes it and their own wishes. I really want to be involved in education, so I got more involved in the program and helped supervise students, but somebody who isn't as interested in that doesn't have to. So I think it's a field that allows us to kind of get involved in what somebody is most interested in, which I think is wonderful.
I feel like we really need another hour to talk to you, but alas, we are limited.
Yeah, if you ever want a part 2, please feel free to reach out.
Yeah, for sure. I really enjoyed this conversation. Thank you so much for your time.
Of course. Thank you so much for having me on. I really enjoyed this time.
This episode is sponsored by Brittany M. Art. Brittany M. Art is a small business started in 2016 and owned by Brittany. Brittany is currently an undergrad science student with a passion for all things artistic. Her mission is to bring you high-quality art that is affordable, as art should be enjoyed by everybody and accessible to all. At Brittany M Art, you can find one-of-a-kind art prints ranging from adorable baby animals to minimalistic nature pieces, all hand-painted with love. The art is available on a range of sizes and also as stickers and even on a canvas. They also love taking custom orders, so if you don't see something that's exactly for you, you can just message them and work something out. I myself have purchased the baby penguin print, which I printed out on cardstock paper to display in my room, as well as a couple mini prints of a handful of blueberries and a watermelon slice. The quality of the art is truly amazing, everything is very cute, and Brittany is super accommodating. If you use the coupon code LIFESCI, LIFESCI, you can get 15% off the whole shop. Check them out at brittanyMart.etsy.com or follow them on Facebook and Instagram at the links in the show notes.
So, when are you going to become a genetic counselor?
So we've got 1.5 more years of university, plus like 2 years masters, and I don't know. We'll see. Maybe. I think it's funny how she was like, oh, I felt that being a researcher, I felt very, isolated. I didn't have enough time with my patients and I wanted more interaction. And I'm over here like, I don't want the interaction. Lock me in a lab.
Yeah, I feel like when she was talking about her journey, I was like, this literally describes Lisa, where it's like...
I guess kind of. Except for I think the way she was describing, it seemed like she was coming at it with a bit more of a I want to help people perspective, whereas for me I'm like, oh my god, look at these cells, look what they can do. So maybe that lends itself more to research, but yeah, I really enjoyed that conversation with her.
Yeah, I thought it was interesting like how her job is not, like you said, it is helping people, but she still gets to interact with the science a lot.
Yeah, that is cool.
Yeah, and then she was saying at the end how like you can kind of take it in any direction.
Yeah,
like education and advocacy and stuff like that.
I thought it was really funny how she calls her patients kiddos.
I think Jana did that too because they
yeah, I guess. Yeah, but Jana works with literal babies and children, like literal children. Yeah, it's just funny because I think you call your floor fellow kids kiddos, and I've taken to calling my TA children kiddos. So
yeah,
it just made me smile every time she used it in a serious way.
Yeah.
In terms of the actual job, yeah, like I do think it's cool that you are kind of simplifying scientific data to patients. And I feel like that's something I would be good at. Like I think I'm good at explaining things. Like I think that's why I'm good at tutoring and that kind of thing. So I could see myself doing that, I think.
Yeah.
Yeah. And I feel like you would have to keep super updated with the science too, especially genetic. Like the field is changing so much. Like every 10 years, there's a wealth of knowledge being produced.
Yeah, for sure. I mean, we even talked about that with the polygenic versus monogenic.
Yeah.
Is that the term? Diseases where like we don't really know that much about polygenic to a level where we can diagnose people.
Yeah.
Or really work with that clinically.
Yeah.
So yeah, I hope that changes in the next few years.
Yeah. I think there are certain terms in science or in medicine where I hear the word and I instantly know what it means. And I'm just so mind blown by the fact that there is a word for this phenomenon that just like encapsulates the whole thing, or that like this phenomenon is considered medically important enough to have like this fancy term. And I think in the case of our interview, that term was gender of rearing.
Yeah.
I just thought that was an interesting way of putting it. I don't know, because it's kind of, it sounds kind of like medical, kind of like a clinical term. I've only ever heard it referred to as, like how they're brought up or blah, 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 blah. But I think sometimes phrasing these ideas in a more clinical way almost allows for conversations where it's easier to talk about it as something important and something relevant to like a kid's health because it has this, official term. Does that make any sense to you?
Yeah, I think so. Like it is a medical element of this person's health.
Yeah. Super. Yeah, that's just like so interesting. And like having to decide the gender of rearing, because I guess, like when you're 2 or 3, even if you don't gender your child, other people are going to.
Yeah, I'm glad she's interested in these topics specifically because for the last 2 weeks in both my evolution classes, I had projects on these topics, so I'm like very in the mood to think about it.
Oh wow.
Yeah. In our discussion class for the society and evolution class, one of the questions that was raised was if we should raise our children like gender neutral, and if that is even possible given that our society is so enamored with assigning genders.
Yeah. So I have a tangent off of this. You know the game Among Us?
Do I know?
Do you know the game? Does everyone listening to this should know the game Among Us? Hi, Dad. There's this game you play on your phone, super popular, multiplayer.
We've also introduced it on the podcast before.
Yeah, that's true. But does he really listen all the way till the end? Hi, Dad. But so Among Us, I play online sometimes. Sad tear of shame. But I do, and it's kind of like a de-stressor tool for me between study sessions. But what I've noticed is that when you play online, you just call everyone he. Like if you're talking about yellow, you'll be like yellow vented. I saw him, all caps. You never say, you don't have the time to like look at their color and look at their head decoration. Is it a flower? Is it a hat? Like you don't have time to like try to gender them. And I just find it so funny because I'm like, this is like, I feel like this is an instance where it's okay to just call everybody he. Because we're just looking for a pronoun. We're just looking for something so that we can talk about who the imposter is. And you can't even feel bad about misgendering someone who identifies as female because it's not like you're looking at their actual body. You're looking at this little cartoon character. With like, I mean, it's so adorable, but it's so interesting as well, you know? Yeah. And so I feel like it would be possible, but it would be, I almost feel like the better thing would just be like to get rid of gendered pronouns in the English language. I feel like that would work better. I mean, I'm not proposing we do that, but yeah, I mean, I think that would be easier than, you know, being like, we're going to call everyone they until, you know, they pick a gender and then we have to remember.
Yeah, I don't want to rehash the discussion, but I think the general consensus was that as a society, we just need to do a better job of not being so aggressive in our gendering for everything.
And you're talking about the English language, like, hello, French. This desk is female. Sorry if if desks are actually male and I just misgendered them.
Yeah, you just misgendered the
out there. I actually have no idea. I have no idea. It's been a long time since I was in FI.
Yeah. And our prof was saying that like he's had, you know, children, and in Quebec, 30 seconds after the child is born, they put like a blue or pink hat on this child. God. So literally starting
that's the worst.
From 30 seconds.
No, that's so messed
just so
up. Why? Done. Wait, but like that's messed up for two reasons. Like the first reason is that you're declaring their gender, but the second reason is that you are saying that girls wear pink. You know what I mean? Like it's like on two levels.
Yeah, so that's kind of what we were getting at, is that like there's just so much ingrained like actions that even if the parents take all the precautions that they possibly could, it's just like as a whole, people interacting with that child are not going to be as careful usually, and it's just you don't even notice to what level this stuff happens. And I'm not saying that it should all go away, but it's just like it's a lot right now.
Yeah, I think it's very much one of those things where each generation is going to be easier and easier.
Yeah.
Look, because I have a sister who's 4 years younger, and I think everyone in her year, or definitely the years below her, put their pronouns in their email sign-offs, you know, or in their Instagram bios. And I think like that's surprising, like 4 years. That's insane.
Yeah. I think you mentioned this where like you were saying we're potentially the last year where we just missed the boat a little bit on that.
I mean, you know, it's not like a hard cut.
Of course, yeah.
I know there are people in my year who do that as well, but I think it's one of those things where it's surprising like how fast social norms change.
Yeah.
Another tangent kind of relating to how language plays into gendering. I remember, so I had an interesting French teacher when I was in grade 11 or 12. I don't remember which one. I think it was grade 12. His name was Monsieur Faber. Very French name. He was a tall fellow with these sharp gray eyes, and I remember him clearly. I remember one day he just brought a log into class, and he was like, I want you to write about this log, and I want you to tell me about how it makes you feel.
What are French teachers, what are they taught in French teaching school? Like every French teacher I've had is just a little bit wild.
Yeah, it was literally a log that he found like on the side of the road, and he was like, "This is gonna be today's lesson."
Yeah, he did not come prepared for that class.
Oh, actually, yeah. On second thought, maybe he just didn't have time to make his lesson plan for that day.
Yeah, that's exactly what happened, Lisa.
But still, like, being able to consider that like an option, man. But anyways, that was Monsieur Faber, and I remember. It wasn't at the beginning of the term, but it was maybe a couple months in. He kind of made this announcement. He was like, like, I don't want to make any assumptions about gender and that kind of thing. So if you feel, so if you want to write your gender when you hand in your assignments and stuff, then I will grade it according to that. Because in French, you can lose marks if you use the wrong adjectival ending because, if you're female, you should put like an ELE. If you're male, you just do an EL. I'm probably butchering that. But so I thought that was kind of interesting.
Yeah.
And if you're like gender fluid, how does that even work? Oh my God. Don't take French. I kid. I actually really do like the French language. I associate with my childhood. So sweet. I think that one thing that has really drawn me away from going into medicine or going into anything clinical is, well, one, I do find the hospital setting and the clinic setting depressing. There is just something about the way the lights shine in a hospital. I don't know what it is, but it just brings my mood down, and I don't know how that would impact my happiness. But the second factor is I really hate the nature of doctor-patient interactions. I actually wrote an article about it that's going to be published in one of our student magazines. But yeah, I basically just wrote a bit about my own experiences with dealing with physicians and how it's frustrating when, first of all, your doctor of, your entire life, literally, still doesn't understand that I can't walk for 20 minutes and, says inappropriate comments that kind of make you question if your pain is even real. So that's frustrating. It's also frustrating that there is such a difference in, I guess, like intellect or power or status between a doctor and their patient. And that is further amplified by the fact that as a society, we glorify doctors. And this isn't just Western society, like, Chinese society definitely does this as well. And that makes it even harder for a patient to have like an honest conversation with their doctor. Like, should I go on this medication? You're like, oh, I shouldn't even have an opinion. My doctor knows everything. But the medication that you should go on it's not completely objective because side effects differ between, different medications for anxiety. And if I have a history of an eating disorder, then maybe I don't want to go on the anxiety med that can possibly trigger like an eating disorder, So, but yeah, so I feel like those are things that have led me away from being a doctor or working in a clinic. So I guess I kind of like how in genetic counseling you do get to have a bit more of like a personal interaction, I suppose. But I think for me, that would honestly be the biggest barrier is, like the systemic barriers to just having human interactions with your patients. So I don't know. What are your thoughts on that?
Yeah, that's interesting to bring up. I was going to say, well, okay, I have a few thoughts, but yeah, I think with the genetic counseling, it does seem a very different setup where she was saying she has like 45-minute, hour-long appointments with some of her families and things like that, which is not how I interact with my family doctor at all. So that's pretty cool. Yeah, one thing about like the dynamics of patient-doctor relationships, I didn't actually think about that before, but that's really interesting to bring that up. I think this is an experience that some of my friends have had when trying to get diagnosed for mental health issues, where the doctor will just not take them seriously enough. And there's just so much variation in the quality of the medical professionals that my friends have seen.
Yeah, for sure.
And yeah, that's just like really unfortunate. And it's like you always just believe the doctor. And we're not saying in general you shouldn't believe doctors. Like you definitely should listen to your doctor.
Yeah.
But yeah, it's just hard to get consistent quality in a lot of those kinds of issues.
Because your doctor is more knowledgeable and they are guiding the process, but you need to have input. You need to have input from the patient.
Yeah, exactly. It's not really about their expertise that's the issue. It's more of have they taken the time to understand what your situation is. Yeah. And there is actually, I think, some hope those kinds of interactions are changing, I think, because some of it just has to do with like how the healthcare system is set up and how money transfers through the system. And that's the interactions are meant to make the money transfers the most convenient in some cases.
What do you mean? Like, do you mean like if they're paid by the hour or paid by the patient?
Yeah, stuff like that. Or sometimes going through insurance influences how a doctor will do things. Just in terms of maybe even the medication. Maybe it's not perfect for you, but it's covered by your insurance, for example, right?
Yeah. Oh, yeah, for sure.
Yeah, there's some new models I've heard in the States. I don't know if they have it in Canada, where it's like a subscription model. So you basically pay this doctor clinic directly a certain subscription every month. And then you're not going through an insurance company. So the doctor has more incentive to actually take care of you. And
what do you mean? You're paying the doctor instead of paying it for your insurance?
Yeah, you're paying the clinic, basically.
I see. So, okay. So I wouldn't have insurance.
Yeah, there would not be insurance.
Huh.
I'm not entirely sure of all the legal discussions around that and how that works exactly, but I did read like a pretty cool article about it and like the benefits about that. So, I mean, I can link that if anyone's interested, but it does seem like there's alternative models who are questioning whether this current system of healthcare is the best way to do things. So
yeah, and you mentioned that a lot of your friends have had difficulty getting treatment for mental health. And I can't even imagine what that's like, because I've had doctors basically just not believe my physical health symptoms. I'm like, I cannot walk. And they're like, is it because you're out of shape? And I'm like, no. It has been 5 years.
Yeah, that's just really unfortunate.
Yeah.
I've seen some research about how that actually influences a lot of pseudoscience being perpetuated, where, you know, people go to their doctors, they're not given the time and attention and care that they need to receive from their doctors. And so they're like, oh, well, this person who's very kind and caring seems to have the right answers. And it's a lot of that interaction really perpetuates people turning to pseudoscience alternatives.
And also, you and I are both people who are biology majors. And I am a molecular biology and genetics student, and if I feel like I am not like able to have a conversation with my family doctor about what medication I should be on, then, you know, what does that say for people who don't even know anything about biology or how drugs affect their body? You know,
yeah,
so
that's
I think
very fair.
Yeah, another interesting point. Definitely a huge power gap there.
She mentioned briefly about how sometimes her patients feel this immense sense of relief when they figured out what the genetic problem is or what the cause is to something that they've been enduring for a very long time. I don't think at the time she knew that this would apply so much to you. We've talked about this before and how this is very much your situation.
I think it's definitely a very common feeling for people who have chronic undiagnosed illnesses. Have you watched that Netflix series called Undiagnosed or Diagnosed?
I have
Diagnosis. It's called Diagnosis. There you go.
It's a series?
Yeah, it's a Netflix series. It's ironically
I think we talked about that.
Yeah, it's ironically about a doctor whose name is Lisa something. And she goes around and, you know, it's a bit of reality TV mixed with actual medical help. Yeah, I mean, I wish I had a doctor actually look that deep into all my testing and see if there's something we can gather from all this different data. I think my dad once said that the Canadian medical system is really good at keeping you alive, but it's not necessarily good at everything.
Yeah, that's fair.
Like if you go to the ER and you're, you know, bleeding to death, they can help you, which is something we should remember and be careful for, but, you know, room for improvement.
Yeah, for sure. I think Julie Nolke actually made a video addressing...
She did?
Not the healthcare system in specific.
I thought you were going to say not recently, and I was going to say how deep down the rabbit hole did you go?
Okay, pretty deep though.
Introduction, Julie Nolke is a YouTuber who we both recently discovered and liked.
She's Canadian. Woo. But yeah, she did a video comparing like the States to Canada. She did 2 videos actually, and one of them kind of is really just in guise of critiquing some of Canada's issues and how we don't pay attention to them.
Yeah, I always say this, like, you can't say Canada's good because we're better than the States.
Yeah, that's fair.
Again, the hesitation in your voice, like,
it's just like I don't think you understand or comprehend how bad the States are sometimes.
This is the Kafka trap situation where it's like, I don't think you know, and I'm like, oh, but I think I know. Like, well, I can't argue against that, I guess.
No, I agree. Canada has a lot to fix, and I have a lot of Canadian pride. Okay, the last kind of interesting thing I wanted to talk about was the whole consent as a parent thing. Even outside of gender and sexuality, like this is a huge topic, and I have no idea how to even approach or think about this. Because as a parent, like, you do have to just make some decisions for your child, right? Like at some point you can't avoid things where your child is just not capable of making that decision.
At that like time. A 5-year-old can't decide which kindergarten they're gonna go to.
Exactly, yeah. But it's like, where do you draw that line? And like, how much control should you have over over this child's life, and but yeah, I don't know, what are your thoughts about this? I have no conclusions.
I mean, you're talking to a woman who doesn't not really sure if they want to have children.
Yeah, that's fair.
Which, by the way, I totally saw you jump onto her being like, oh, maybe it's a little hand wavy about how women over 35 are at high risk pregnancy.
Yeah, because there's very few people who are able to shed some light on that. Like, she has a genetics background. She's, a pretty woke person. So
I thought you were just going to say pretty person.
I don't know what she looks like.
I was like, what? Yeah.
So yeah, I feel like she would actually have an opinion worth listening to, I think, on that topic.
Yeah, for sure. I mean, it's strange because in the vast majority of relationships, parents want the best for their children.
Yeah, for sure.
It's weird because, probably because it's what we grew up with, where like, yeah, no, obviously like the parents should decide what kindergarten you go to. Like, that's for sure. They should decide if you get vaccines or not, although that one I'm like a little like, oh, maybe it should be mandated, But yeah, and like if you need to get open heart surgery, of course the parent can like sign off on that. But I don't know why when people bring up like if your parent should decide if you get circumcised or if you have surgery for like an intersex kind of situation, I don't know why my brain just automatically goes no. And I don't have a logical justification for it because, if I'm saying your parent can decide if you have other medical operations, like, Jackie was saying, why can't they decide if you have an operation relating to like your genitalia or your gender?
Yeah. The other context in which I think about this a lot is like career stuff, where it's like early on, I think your parents do make a lot of decisions about like, schooling and educational stuff and your interests and things like that. But yeah, just like figuring out the degree to which they should be involved in that is kind of tricky.
Yeah, for sure. And I think that depends on the family and a lot of the times the cultural context.
For sure, yeah.
Yeah, super successful interview. 10 out of 10 would do again.
Might do again.
This has been another episode of So You Got a Life Sci Degree with Jacqueline Leonard about genetic counseling. We want to give special thanks to our crew of lovely patrons, including our Little Leaf patrons Naeem, Daniil, Shafiq, and Shamima. If you would like to become a supporter of this podcast, you can visit our Patreon at patreon.com/soyougotalifescidegree. You can also rate us on Apple Podcasts using the link in the show notes. The music you're hearing is No Regrets from audiohub.com. Thanks for listening and see you next time.